Well, you've heard from Dr. Emanuel and Dr. Conway about the case for change in oncology care. We feel and deeply believe the problem is truly rooted in our traditional fee-for-service reimbursement model. Our collaboration with Dr. Pecora's group in rolling out bundles in New Jersey stems from a sense of urgency, common purpose, and shared values to evolve the fee-for-service model to what we call a value-based model, and the episode of CARE, or EOC acronym, is an example of that. As we discuss these materials with you today, I think it's really important if you take one point away from this discussion, let it not be a particular design approach for an episode of CARE, but understand that we are in the early stages of a movement to build a better healthcare system, not bound by historical and political considerations, but driven by science, teamwork, and compassion. I have two slides, and then I'm going to hand it over to my colleague, Dr. Pecora. On the first slide, I'll discuss our objectives and policy behind them. And the following slide, I'll outline at a high level bundle construction and payment. So on my first slide, 5 objectives. And the first one, establish transformative patient-centered partnerships based on quality, not volume of services. I should say, at Horizon, we see episodes of CARE as part of the new framework required to improve the delivery of healthcare services and rationally address these spiraling costs. We may call these pilots. However, we're committed to learning from these experiences and implementing new reimbursement models based on value, not volume of services. So I think you can probably hear in my voice, this is not a pilot for us. The other point, in an episode of Care Design, you are truly changing the basic relationship between providers and payers regarding clinical advocacy and cost management. In the fee-for-service world, we payers, we monitor and improve payment, and we diligently work at trying to improve the safety and quality outcomes for our members. However, our ability to monitor payment is far more precise than our ability to monitor safety and quality, and the major limitation is that the information is not housed in our administrative claim database, but rather in the physician electronic medical record or patient chart. So if we're going to transfer and shift financial oversight to providers, we must be able to monitor safety and quality more closely. And the great part here is that we have that technological capability today, and Dr. Pecora is going to talk about that in a moment. Also, the next problem to solve for regarding cancer and ultimately all diseases and conditions are the inherent limitations in our current reimbursement language in ICD-9 moving to ICD-10. Our classification system, as many of you know who are on the line, is built upon an anatomic taxonomy. And we need to recognize that we're in the molecular age of medicine, and our classification systems must reflect the science of the day. We also have that technological capability to properly classify diseases, recognizing the molecular nature of the illness and the growing list of therapies that will act at the molecular level. And Dr. Pecora has worked with us and has brought technological solutions to address that in partnership with us. Stepping back, just a remark about insurance in general. For insurance to work, you have to be able to pool similar risk. If you're pooling dissimilar risk, then proper attribution does not happen, and that leads to policy and pricing issues that undermine the affordability and the implicit assumption that we are paying our fair share. So, for us, you have to have a classification system that allows pooling of similar risk. The second objective, there is widespread agreement that reducing variation in care to eliminate waste and inefficiencies is a worthy goal. I think the debate has been more about how do we accomplish this objective and how do we prioritize the interventions that have generated many sound ideas, from greater fraud enforcement to better care coordination as two. Our perspective is that the single most important intervention is reimbursement reform, and the lion's share of our efforts together should be aimed here. Third goal, align financial incentives by emphasizing safety and quality outcomes. I think everyone understands in a fee-for-service environment, payment is made regardless of health status or outcome. In our episode of care approach, at Horizon, working with the oncology community, we will couple the shared savings if and only if foundational quality metrics are met. You have to pass through this door first to realize additional payments with us. The discussion here regarding safety and quality metrics were spearheaded by the practicing oncologists, and in their traditional role as truly staunch advocates for superior patient care. In the next slide, I'll delve into this part a bit more deeply. Our fourth objective, restore physician leadership and decision-making that improves the patient relationship and increases administrative efficiency. No doubt, the age of managed care fundamentally changed physician practice, most notably in the late 80s through today. We see the EOC models also as a means of restoring the primacy of the physician-patient relationship, and in doing so, we believe will relieve physicians of the administrative burdens of utilization management and still accomplish the appropriate provisioning of care. Over time, it's our intention to completely uncouple traditional utilization management from the physicians participating in these bundles and models, including, but not limited to, inpatient hospital review and prior authorization. We truly envision the physicians as the captains of care, leading the charge, leading the change, and recognizing our hierarchical role here as a managed care company as being more supportive and less intrusive. And the last one promotes access to high-quality, affordable health care while improving the patient experience. You know, you could also have that as a vision statement or an expression of vision. This objective, no doubt, could be found in the marketing materials of many healthcare companies. I think the point I want to impart here of why we have it is that when you try and strike a new relationship with physicians and you use terms like partnership, you really got to be serious about building trust, especially after the past few decades. Our intent here is to be fully transparent with both our motivation and our strategies with the physicians. And here we're talking about the oncology community, obviously. And for that change to happen, and for physician and payer institutions to join side by side, we both have to begin believing that these goals are not just words on paper, but words that guide conduct. So if we can go to the next slide, please. And Catherine, you'll just have to let me know if we're there for the...
Yeah, we're there.
Okay, thank you. So we have a picture here, a shot of the payer, patient, and physician, and looking through the lens of an episode of care. And what I'll do is I'll touch on a few highlights through that lens of how we look at bundles and how payment will take place. So first, from the payer perspective, we constructed our bundles by including all the care, all the treatment related to the oncologic diagnosis itself, all the medical, all the RX. All the non-related care in our first phase is excluded. And this, I believe, if I understood Patrick correctly, and Erin, is a bit different from the CMS model. Eventually, we plan to incorporate the total cost of care, but for the time being, we felt there was a learning curve here for the oncologists, and it is our intention to gradually support their transition to managing the cost of care in addition to their regular clinical duties. Examples of excluded care would be a broken leg, for instance, secondary to trauma, unrelated to a neoplastic lesion. The next thing here is that the idea is to get physicians comfortable in this role. So our bundle initially is a hybrid approach, combining fee-for-service with a retrospective review of costs. And it works like this. So we've met with the oncologists. We've agreed to a bundled price. We base it on historical data of at least 2 years, removing outliers, both high and low. We agree on the time period. We agree on the safety and quality measures. The bundle begins, and the oncologists and all the other providers start delivering their typical services to the patient. And they continue to be paid on a fee-for-service basis within the first phase of our bundle. As the bundle begins to complete, we see and assess the safety, quality, and cost in the bundle. If the safety and quality thresholds are met and there are savings, we share those savings with the oncologists. Our thought is this approach minimizes the potential pressure and influence to immediately manage total cost and creates the right tone for a collaborative relationship. We designed this first phase emphasizing clinical outcome as the overarching goal, and eventually, as we gain more experience, the bundle and payment will be completely prospective in nature. Now the patient lens. Our technology platform, and Dr. Pecora has a very detailed talk on this in a moment, will capture all the clinical determinants of care and provide this information back to the physician, leading to faster recognition of effective therapies. The oncologist, going forward, it will be unencumbered by prior authorization and will have the authority to make referrals for diagnostic testing and therapies without seeking approval from an insurance company like myself, like Horizon. It will be much easier for patients to navigate the system in this type of environment. Over the decades, utilization management programs, they have presented and have been a significant factor for patients and physicians in their relationship. In the bundle environment, we intend to dismantle these programs with the aim to completely eliminate them over time. And ultimately, again, it's our belief that this will make for a far superior patient experience. And finally, the physician lens. No doubt, physicians, at least of my generation, and I'll have to include Zeke in that remark, went to medical school with the notion that our daily focus was on patient care and it would be centered around outcomes and metrics like, what you've heard before, overall survival, disease-free progression, appropriate treatment, and functional status. And we didn't, hear the calling and become physicians and think we would be worrying about authorization from insurance companies like mine. The bundle now allows us to get back to that original focus about where our attention should be centered. The safety and quality metrics were developed in partnership with the oncology community, and many of the specific metrics Dr. Emanuel discussed are incorporated in our early bundles. We made truly a conscious effort to maintain a manageable number of metrics, specifically some examples for you, where the intent is curative, high level, and the delivered dose intensity should be at least 80% or greater with 90% compliance. Another example for disease-free progression, we will use peer-reviewed literature and benchmark that and perform within 10% of that number 90% of the time. And for functional status, and we too are using the ECOG, and for those of you not familiar with it, it's the Eastern Cooperative Oncology Group Performance Status. We will be looking for a level between, and Zeke said quite correctly, between lower is better, 0 and 2. And 0 is fully active, pre-disease level, and 2 is ambulatory self-care, but you're not at a level to work. And we would like to see that at that metric at 75% absent any significant comorbidities. So that's a brief introduction into some of the policy considerations about how we look at moving to a value-based system from a volume-based system in fee-for-service, and how we're going to start this approach, which is our strategy. And in closing, let me just make a few more remarks before I pass it to Dr. Pecora. Please appreciate that we are at a tipping point of monumental change, and we have to rely on the strength of the growing partnerships between providers and payers to develop the necessary, I would say, 1, classification system built for a molecular taxonomy. 2, we need the software technology to support the current science. And 3, we have to align the reimbursement models. For us, today we're in the molecular age of medicine, and we feel that physicians will have to lead these innovations and create the evidence based on benchmarking and approaches to improve the clinical outcomes and help manage costs. And payers like myself, we need to play more of a role of providing the data, the analytical and administrative support. And now it's my pleasure, I'd like to hand over the next portion of this presentation to Dr. Pecora, who along with his colleagues truly have been the driving forces for our discussion today.
So I just want to take a step back before I get into the detail of what I'm going to present briefly and tell you a little bit about why myself, my over 100 clinical colleagues at Regional Cancer Care Associates, and my academic colleagues took time away from their academic duties to work on this at the Jones-Orr Cancer Center at Hackensack. We have spent as a nation billions upon billions of dollars over the last 20 years on the development of new therapies, new technologies that has really transformed cancer from a uniformly fatal disease to one in which when I go see patients, which I still do, can walk in a room now and offer patients cures instead of months to live. And it would be an absolute tragedy that we get to the point where we cannot afford to offer patients access to potentially curative therapies. And that, more than anything else, drove myself and my colleagues to get engaged here and figure out, this is why we need to do it. What do we do? And it really comes down, when you do the math, to two possibilities. One is to ration care, which I don't think anybody wants to do. And the other is to build a system that can be scoped nationally that provides rational care. The Goldilocks formula, not too much, not too little, just right. Do what you need, no more, no less, but do that at scale and do that as best you can almost all the time. You heard before from Dr. Emanuel, there is actually peer-reviewed data that shows if you do too much, and surprisingly, if you do too little, it actually increases total cost of care, and it decreases clinical outcomes. So the question became, all right, so you know what you need to do. You need to drive out waste and inefficiency. You need to optimize care. You need to enact the Goldilocks formula. How do you do it? And we spent the better part of a decade thinking about this, and then in the last 3 or 4 years working with Horizon, and now working with Dr. Emanuel. And it came down to two components. On this slide, and I'll read part of it briefly, the Institute of Medicine in September 2013 very succinctly stated one of the core components needed to change this at scale. And it reads, the committee's conceptual framework for high-quality cancer care delivery system calls for implementation of a learning healthcare information technology system, a system that learns by collecting data on care outcomes and costs in a systematic manner, analyzing the captured data both retrospective and through prospective studies, and then using that knowledge to change behavior. So the bottom line was we needed a GPS system for cancer. So I had the privilege of working with brilliant developers, mathematicians, and biostatisticians to work on a software called COTA that is now being used by several major medical centers in the United States, and I think you're going to be hearing a lot about it as time goes on. The other is, what can the oncologist do, and how do we work with payers to change reimbursement? We too agree that the traditional fee-for-service reimbursement methodology is not appropriate for today's medicine. And we came to the conclusion that bundled reimbursement was the way to go. And the core principles for bundled reimbursement, in order to enact this, and throughout everything else I'm going to say, the two core objectives are you must maintain or improve clinical outcomes while you're controlling costs. So the first thing is, in order to do this, you need a common sorting language. We are in the era of molecular medicine. How we characterize disease today is fundamentally different than years ago, and over the next few years, it's going to change again and again. And you need patient-specific disease characterization to the highest level of relevant clinical and molecular phenotype, and this will allow for meaningful comparisons of clinical and cost outcomes and for common bundle inclusion criteria. You wouldn't walk into a supermarket and take the apples, pears, and peaches and mix them all together in one bucket and then try to figure anything out. You would separate them into their own buckets, and then you would try to figure it out. And that's what we have to do up front in order to have meaningful data on the back end. Bundled reimbursement must be accompanied by transparent, real-time outcome reporting to ensure that expected clinical outcomes are not compromised. Patients, payers, government, everybody's going to want to know that if we change the reimbursement system, there's some way to check that the change in the reimbursement system did not compromise quality, that you're sacrificing clinical outcome to save money. That will not be acceptable, and it needs to be transparent. Bundled reimbursement must reward better clinical and cost outcomes, not just cost, and be associated with financial risk. It's fundamentally important that physicians are at financial risk because that will modify behavior. Patients can't be at financial risk. Clinical outcomes can't be at financial risk, but physicians need to be at financial risk, and in the way that was described by CMS and by Dr. Pomerantz as examples. Bundled reimbursement must be enabled for all existing and future electronic healthcare records. Doctors and nurses cannot do double data entry. This has to be a technology solution. And finally, bundled reimbursement should be tied to attaining or exceeding an expected clinical outcome and not compliance to a specific therapy pathway. There's nothing wrong with therapy pathways. But if you look at the gold standard in oncology, the NCCN guidelines, you have 5 or 7 choices. Telling someone you should do choice 1 and not 2 doesn't take into account patient preference, physician experience, and many other things. So really what matters is, did you hit the outcome you intended, not how did you do it. So next slide, please. So very briefly, the concept is, up front, you have to spend the time in sorting the patient, getting that molecular clinical phenotype, doing the genetic testing, the genomic analysis, and other forms of testing that are requisite for a specific disease. You also do this not just up front, but you do this at the times of progression, because at progression, the disease changes. And that is the pivot point from which you can track your outcomes. And then finally, in order to keep physicians on course, sort of like Six Sigma, you don't want to wait until someone goes off course. You don't want to wait for a plane to crash, so to speak. You want to give plenty of advance notice. So you have to have a technology, a system that allows you to tell someone you're trending off course so you can correct your course and avoid a variance. If you go to the next slide, please. I'm just going to show you a very brief example. So the disease of lymphoma, I know there's many non-physicians on the phone. A lymphoma, there has to be at least 30 or 40 different types of lymphoma. And if that's not complex enough, if you can go to the next slide, there are subvariables that absolutely influence the expected outcome and the subsequent cost of caring for those patients. So if you don't account for the relevant variables and the variables that are important at the time of diagnosis, at the time of each progression, and they change as you progress, then looking at claims data, looking at big data sets, is going to be filled with a lot of noise, not all be all that valuable, and potentially could give rise to misleading information. So you need to do the work, and we cannot be afraid of complexity. In fact, we should embrace it. So next slide, please. So Dr. Emanuel described this, and this is what we're going to be doing. So the outcomes that matter are the type of therapy, is the intent curative or palliative, the time to response and the best response you achieve, your survivals, your overall survival and progression-free survival. Dr. Emanuel talked about delivered dose intensity, incidence and severity of toxicity, ECOG performance status, and cost. In the curative, when your therapy is curative intent, what matters more than anything else is, did you give the proper doses of the proper drug on time, and that's delivered dose intensity. When you cannot cure a patient and you're palliating them, really quality of life, not that quality of life isn't important in the curative setting, it is, but it is paramount in the palliative setting. And we chose to use ECOG performance status as the indicator. When a patient walks in with metastatic cancer and they're feeling poorly, they're in bed 70% of the time, and you can give them a medicine to make them feel well again and go back to work, that's valuable. But once they start getting sick again, instead of giving a second or third line regimen that can't make them well anymore, then it's time to do something different. And this is what we'll be allowed to do. You need to be able to benchmark. Next slide, please. Patients need to know that my doctor is hitting the standard. Payers need to know that. Administrators need to know that. And the tool that we're using allows us to do this. We can benchmark against clinical outcomes, progression-free survival, overall survival. If you show the next slide, please. We pulled data in lung cancer patients from 2008 to 2013, and we looked at the cost of 2 regimens, and one that was less than $10,000, one that was greater than $10,000, and then we looked at the clinical outcome. And the clinical outcomes were superimposable, but yet one cost significantly more. This allowed us to convince our physicians internally that the less expensive regimen is just as good as the more expensive regimen, so give the less expensive regimen. We didn't make them do it, but the data changed behavior. The next slide looks at outcomes versus dose intensity. I'm not going to spend time on it other than to show you that this is a capability. The next slide. a very important slide, outcomes versus toxicity. There are certain regimens that have very significant side effects. They lead to poor performance status, but they're given. And yet, they're not tied necessarily to outcomes. So when you look, at least in this particular circumstance, between two different regimens, not only did one have much greater toxicity, but it also led to a much less desirable outcome. And that would not be a desirable outcome overall. Next slide, please. You have to notify physicians not when they're doing well, not when they're on course, when they're going off course. No different than when you're driving down the road and you have your GPS on and it tells you, you should make the left because you need to get back on course. And you want that to happen as early as possible. So we've invested in the time and the necessary technology infrastructure to make this a reality. And it's all pivots off of where the patient is, like I said, this GPS concept. Not just the clinical molecular phenotype, but also where are they in the history of their disease and what is the intended therapy they're receiving. And that allows you to use those nodal addresses to send content to physicians that's meaningful and that could change behavior in real time. So the last two slides I'm going to show you are actual abbreviated bundles. And so Regional Cancer Care Associates has created bundles for breast, colon, lung, lymphoma, and we're completing bundles now for AML, CML, and for prostate cancer. And we're going to be doing those in partnership with Horizon and hopefully other payers. And here is a list of specific clinical molecular phenotypes, and you'll notice they're different. But it turns out that if you take all of the potential possibilities of breast cancer, there's over 1 trillion. Now, no one could ever manage that number. But when you look at what's clinically meaningful, it filters down to only a couple thousand. And a couple thousand can actually fit into 6 to 8 bundles. Even though they're different, they actually get treated the same, the different phenotypes. And so on the last slide is an example of a bundle. And it's very granular. And the one thing I want to point out, and this is what I'll leave with, is how do you iteratively drive value? Because this is not a static solution. This is a dynamic, iterative solution. So it turns out, as I said before, that there are 3 chemotherapy regimens that are equally approved and will give you the exact outcome. And doctors have preferences because of clinical training, experience, or other reasons. And what we have agreed with the payers is we will look at the clinical outcome, the toxicity, incidence and severity, and the cost. And at the end of 1 year, we will drop off regimens from our individual formularies with the doctor's approval because a regimen may be associated with an equal outcome, but it costs more or it causes more side effects. So in closing, I want to thank everyone for the opportunity for participating in this, and I particularly want to thank for Horizon for having the courage and foresight to work with us on this important endeavor. So thank you.